Welcome everyone. My name is Boldizsár. I would like to present my 6-month progress report in Translational Medicine program. My vision is that the best medical knowledge needs and practice needs a constant update by scientific research. And my mission is to develop and refine intensive care strategies for resuscitated patients. We set some specific goals in translational medicine. The first one is an investigation of prediction scores in out-of-hospital cardiac arrest. The second and third one is a comparison of prophylactic and clinically relevant antibiotics after successful resuscitation. In the next slides, I would like to talk about my progress in the first topic. We already know about the cardiac arrest, that the incidence of out-of-hospital cardiac arrest is between 70 to 170 per 100,000 per inhabitants per year in Europe. And despite advantages in resuscitation, the survival rates and the success rates at the hospital discharge are on average 8%, which is a very low number. This study could clarify the question, which score is the best for estimating neurological and survival outcomes after successful resuscitation. In the clinical practice, using prognostic score systems can prevent the healthcare system to apply costly and intensive resources in cases of futility. Our clinical question is the following: which is the most accurate and reliable prediction score system in out-of-hospital cardiac arrest cases after successful resuscitation? Below the question, you can see our Pico Framework. We made a systematic search in 4 databases last year. The search key at the bottom. On the right side, you can see the flowchart of the selection. Before the results, I would like to define 2 things to make easy to understand the next slides. On the one hand, the CPC scale, the Cerebral Performance Scale, is the commonly used scale to categorize the neurological prediction in the studies which work with neurological prediction scores and neurological prediction. It gives two categories, the good and poor prediction. The CPC 3.5 is a poor neurological outcome, and the CPC 1.2 is a good neurological outcome. On the other hand, the studies that we included with rock curve, the studies visualize the accuracy of the score system, and with the AUC, the area under curve, they quantify the accuracy of the score system. The bigger AUC means the better accuracy of the prediction score system. The first one is the CGRAPH score, which is stratifies neurological outcome after out-of-hospital cardiac arrest in patients receiving targeted temperature management. It contains 5 dichotomous variables. We found 3 articles and 3 cohorts which uses CGRAPH score to predict neurological outcome at hospital discharge. The population is homogeneous, and the pooled AUC of the 3 cohort is 0.80, which is quite a good accuracy. The second score what we investigated is the Orca Score, which predicts neurological outcome as well in patients, Orca patients admitted to the ICU. We found 5 cohorts in 4 articles. The heterogeneity was 0, and the pooled AUC of the 5 cohorts was higher, 0.84. The third score, the CAP score, which is a simple tool for neurological stratification of OHCA cases in ICU admission. It includes 7 variables. We found 6 cohorts in 4 articles, and the heterogeneity was high, which can explain by the various rate of average age in this cohort, and various rate of targeted temperature management therapy application. The pooled AUC of the 6 cohort is the highest, 0.89. The last one, the last score what we investigated is the SOFA score, which originally a mortality prediction score based on the degree of 6 organ system dysfunction, and it can be used with all patients admitted to the ICU. We found 3 articles and 3 cohorts which uses the SOFA score to predict 30-day neurological outcomes. The heterogeneity is high as the last one. It can be explained by the various rate of shockable initial rhythm and the various rate of cardiac etiology in these cohorts. The pooled AUC is the lowest, it is just 0.67. With the same outcome, we can set a hierarchical order between these score systems. So we can set in one hierarchical order the CAP score, the OHCA score, and the CGRAPH score. And I said before about the AUC, the bigger is the better. So the CAP score is the most accurate CAP score system to predict neurological outcome at hospital discharge. To close the results section, I would like to talk about the promising Stenhausen method. If we get all the individual data from the studies that I showed before, we can able not just make a pooled AUC from the individual AUCs, we can able to make pooled rockers from individual rockers to compare the several score systems, and we are able to make an optimal cutoff value each score system as well. To summary, the strength of our topic is that hierarchical order can be set between the score systems in each outcome, and there are some limitations as well. Not all score systems had enough publication to include in the meta-analysis, and in the analysis we have a lot of retrospective cohorts. In the practice, the high-risk category of patients with poor prognosis can be easily identified with the best prognostic score system, and we can prevent, as I said before, we can prevent the healthcare system to apply costly and intensive resources in cases of futility. In the field of research, more studies are needed which investigate these prediction scores in prospective way. And we can conclude this topic when we finish the whole statistical analysis in each outcomes. In the remaining time, I would like to talk about my second project, prophylactic versus clinically driven antibiotics after successful resuscitation. About the background, the early onset pneumonia is a frequent infectious complication after resuscitation due to potential aspiration and immunological impairment as well. Now there are few available data with the early timing of antibiotics could efficiently reduce the risk of pneumonia or any other infectious complication in the ICU. Our aim is to compare the effect of prophylactic antibiotics with clinically driven antibiotics. Regarding this, our clinical question, does prophylactic antibiotics decrease the rate of mortality and incidence of pneumonia compared to clinically driven antibiotics? And our hypothesis is prophylactic antibiotics is superior to clinically driven antibiotics. The clinical implication would be decrease in mortality or incidence of early onset pneumonia and any acquired infections. We made a systematic search in the last year in 5 databases. The search you can see below. And in this slide you can see the flowchart of the selection. And now here we are. In March we are planning to start our third project, which is a protocol of randomized controlled trial in the same topic as a second. Last but not least, you can see an overview about my topics, and thank you for your kind attention.
Congratulations. Actually, the first meta-analysis has great results. I have questions regarding the second study. Just a quick question, because it is related also to the trial. I think we already discussed that the 3-month progress report about the patient group that you are including even in the meta-analysis, but also in the trial that you want. What kind of resuscitated population will this be? What is the cause of death in this patient? Is it defined, or is there any exclusion criteria, inclusion? Because you know, most of the patients actually who will be resuscitated in the hospital, probably they will also get in the hospital some kind of antibiotics for treating the disease that they are there. For example, they have sepsis or...
We are focusing on out-of-hospital cardiac arrest patients. In this population, the etiologies, the main etiology is cardiac etiology, myocardial infarction. As in the real life, we get heterogeneous population as well, and the studies works with heterogeneous population as well. So we are just the include criteria is just out of hospital cardiac arrest. Nothing special.
But you want to give prophylactic in one arm and the other arm?
Yes.
I think it also, there will be an important question for who to give antibiotics. Not, of course, you won't need to give for everybody, but also you have to do all the subgroup analysis to find out the best population for this. Thank you.
Thank you.
One additional information that we will exclude all those patients who get already any kind of antibiotics, because we cannot put them into the population at all. And most of the patients coming from the field without any treatment or with any kind of treatment without antibiotics, but we can have the heteroanamnesis, the history from the family or the relatives, and we can get all this information about it. So I think most of the patients are cardiac arrest patients due to cardiac origin. We'll exclude also the traumatic patients as well.
I would like to also ask a question. How many patients do you expect in the randomized controlled study later on? What is the out-of-hospital cardiac arrest turnover in the Heart and Vascular Centre of the Semmelweis University?
It's around 60 or 80 patients per year.
Mm-hmm. Thank you very much. And to the antibiotics, I would like to ask, do you use a broad-spectrum empirical antibiotic prophylaxis or treatment in this case? What would be the approach?
In the studies that we included a second project, they used amoxicillin clavulanic acid.
Mm-hmm.
We are planning to do the same, I think.
Okay, thank you very much.